I've enjoyed this morning. I have to say, slightly depressed watching what's happening around the world. But it sort of got me thinking that I was director of one of the largest marriage and relationship counselling services in Ireland for 7 years. And in that, we would have worked with many couples. And definitely what one noticed in relationships, even where there was absolute loving couples who loved each other and wanted to stay together, that human beings, even in adult intimate relationships, have a tendency both to be loving and also to be abusive in its many forms with each other. So I think background in terms of my thinking with this is, if we think back to Thomas Hobbes, we think of philosophy and the need for a leviathan to regulate human behaviour so that we behave well to each other. It reminds me a little bit of this, that any person, any human being has the potential to be compassionate, good and caring, and also has the potential to be abusive, aggressive to another human being. And I think we really need to accept and recognise that. And looking at some of the international literature, it really is the thing, not being afraid to accept and recognise that at given times we can have systems in place where the vulnerable will suffer. And it is the vulnerable that tend to suffer. Thinking of the poor human beings who drowned coming across the Mediterranean, it was highly noticeable to me that the less vulnerable people, the men, tended to survive, and that the poor vulnerable, particularly the women and the children, are lying at the bottom of the Mediterranean. So I suppose when I get into this in terms of regulations, I sort of wanted to underpin that at all times we're conscious of, we're regulating a sector where the most vulnerable are. So just to give you a sense of what we're about in HICWA. HICWA is about driving high quality and safe care for people. It's about putting people first. It's about fairness and objectivity, openness and accountability, excellence and innovation and working together. And they're not just pieces of paper on a page. Living that and being that creates a high level of stress in individuals in trying to achieve that. We are interested in the research, we're interested in being balanced and proportionate, but above and beyond all that, we're interested in action, in where we stand now at this current moment in time for the people who are living now within the sector, for the people who are working now within the sector. So we recognise that there's a lack of research in the area, but I think even a blind man can see that older people are abused, that vulnerable people are abused, and that's happening now in every country in the world and in any setting in the world where a vulnerable person exists. It's about having the maturity to have a balanced conversation and a balanced way forward to mitigate that, but also not to ignore it. So not to catastrophize it, but to recognise it. So in HICWA, we're about looking at the reality. Just to give you a sense of how we work, we basically, the Health Act 2007 was enacted in Ireland. There was a couple of issues that led up to that. But probably the main thing that happened was there was a nursing home called Lee's Cross, and there was clear evidence of abuse in that nursing home that was captured by an undercover camera in Ireland by a programme called Primetime. And obviously, when people see the reality, when they're woken up to the reality of how human beings can behave, it creates a reaction. And the reaction was, and the right reaction in terms of the government at the time was, how can we put in place structures and laws to give optimal protection to people? And out of that came the 2007 Health Act. And from there, a large amount of powers were given to the Chief Inspector of Social Services in Ireland, who is also our CEO in HICWA, Mr. Phelim Quinn. At the moment. So we have a huge amount of power, and that power is basically, the main power is that anyone who is carrying on the business of a designated centre, which is basically nursing homes, for want of a better word, and some of the public services in the HSE, they must be fit people to carry on the business. They must prove that to us, that they are fit people. They must be in compliance with the regulations, and the regulations are called the Care and Welfare Regulations. And if you think of that name, the idea of someone's care and welfare is being looked after. It's a very positive way of looking at something that the whole sector is agreed, and I think everyone is agreed, that if these regulations, these care and welfare is in place, well then we can carry on in terms of quality improvement, etc., etc. There is also a number of standards then. We have the National Older Person Standards, which have been reviewed, and a new version is coming out this year. But again, those standards were from a group of people coming together, articulating what we think is the right way people should be treated in older people in terms of their care and welfare. So what we do as a regulator is, we basically, every 3 years, we look at all the providers rigorously and we form a view as to whether they are fit or not. They must evidence their fitness to us through compliance with the regulations and standards. If they're not fit, they will not be registered. We take a very simple view. Caring for the most vulnerable is you know, it's not something that occurs by right. And you'll see this in society. Sometimes you can have competing rights. So in our constitution, there are many rights articulated. But generally what you find is the rights of the most powerful tend to get vindicated quicker than the rights of the vulnerable. So even in the rights in our constitution to carry on a business, to gainful employment, etc., etc., that competes with the right that we're enforcing, that actually, no, you must be fit before you lay hand on any elderly person, or you organise a centre to look after elderly people. Now, in general, I have to say, just to give you a sense of the sector we're talking about, so we're regulating a sector of about 600 centres, designated centres, and about 30,000 older people. By definition in the Act, those people must be dependent persons. So the Act says a designated centre is a nursing home or that place where dependent older people are being cared for by virtue of their dependencies. So by definition, the people in there are dependent, and I'm only talking about 30,000 people. I really want to get across the idea of, because I'm very interested in safeguarding and avoiding any vulnerable person or any person being abused, the function of regulation. Service delivery and performance management are matter for the service provider. So we have a lot of providers in Ireland, a lot of fit providers in the public, private and voluntary sector. The matter of carrying on that business is for them. Regulation is concerned with how well or otherwise they fulfil that task. And it's very important in terms of, you know, not getting captured in the wrong place, really. We want to do our job objectively to make sure that the fit people are carrying on their job. Just to say in terms of regulation, like anything else, has to be open and accountable. Regulation, and internationally you will see this, it has its good days and bad days, and ebbs and flows, and the principles around regulation change depending on what has happened in external society. So, for example, a number of years ago, the narrative around regulation would have been about regulatory burden. The state creating a regulatory burden on the free citizen stroke provider who was trying to carry on their business. That would have come out of a number of industry-based regulation things. There was different reports, Cadbury reports, etc., etc. So there was an emphasis in terms of regulatory burden there. Then we have the bank collapse, and the narrative changes to, well, actually the regulator, you know, why are you concerned about burden about, you know, people out there? Your job is to protect people, protect the citizen, etc., etc. So the narrative changes. I think the narrative at this moment in time in terms of older people in Ireland is relatively balanced. And I just want to go into that in terms of the approach that we're taking. So we have a number of principles. Out of the different reports on regulation, we've come up with a number of principles of how to regulate people and how to ensure the care and welfare of the 30,000 older people is attended to. And really what we're trying to get at is transparency, accountability, targeting, and I'll come back to that, consistency, proportionality, even-handedness. Now, some of those principles are very easy to agitate around. So very often the narrative we might hear from providers is, oh, you're not being consistent. And that's fair enough, and it's an easy point to prove. But as a regulator, my eye would be all the time around targeting accountability. All the time on that. I'm prepared to give and take on the consistency if everyone is being protected. So if people are being cared for. So in the narrative, you will always have a number of debates with all the different stakeholders. Genuinely, I would say that the majority of stakeholders I've encountered, and I've been in this role since 2009, are actively interested in doing the best they can for vulnerable older people. I would have to say that. I've come across 2 or 3 people, one provider particularly, who had no active interest in older people. Their only active interest was in their own pocket and in their bank account. They're now gone out of the sector. The report is published. You can go onto our website and you'll see it. It was a nursing home in Kilkenny. The report is published. The person disappeared out of the country. That's how actively they were concerned with older people. Then you'll come across providers who are badly informed. And I've come across 2 or 3 of those people where you're sitting there working with them and you can actively see they don't know what they're talking about. They haven't a clue what they're doing. And so people are suffering. But the majority of providers are well-intentioned and well-informed, and that goes across the public and the private sector. And that, I'll bring you back to then, why then is there the potential for neglect or not safeguarding people? And that comes back to how you think about things and the systems underpinning it. So our principles, I just want to show you, we present this to our inspector. So anyone out there who's interested in older people, has qualifications in older people and is interested in making a difference, we're always looking for people like that. And what we do is, I want to give you one of the slides that we're doing with our induction. What we ask them is, they prepare thoroughly for inspections. They focus on a key outcome question. What is this centre like as a place for people to live? They'll interact with a wide range of people while also observing keenly. We're not interested in a tick box exercise. They'll write timely reports which are fair, clear, informative, but do not shirk the hard issues. So a balanced report isn't a report that shirks the hard issue. A balanced report is a report that puts in the hard issues, and so that people are absolutely aware of it. They do inspections across the 7-day week and 24 hours a day, and they'll make timely and evidence-based regulatory judgments, just to give you a sense of what we expect of our people. As a regulator, in trying to be a good regulator, we're trying to really commit our people to making a difference. Quality in your own work, individual accountability in your own work, a genuine empathy for people, a strong personal ethic of concern for people using services, vulnerable people, and being able to open yourself to the experience of others. That's something in the system that we watch time and time again. Human beings, if we think of our compassionate side, when we see something that's wrong and when we see something that disturbs us, it's very easy to turn away. There's nearly a natural instinct to turn away from that and think there's a reason for that, or construct some narrative around that. What we say to our people is, when you see something that's disturbing, walk towards it. Just untangle it, walk towards it, speak to people, look at documents, and try and gather what's going on there. And have the courage to do the right thing and be committed to making the often tricky judgment. It's in our profession, you worry when you don't have an inspector who hasn't got a complaint against them. You have to do the right thing. You have to be able to make the right calls and not to be afraid of that. Responsive regulation. So some of the principles that we're trying to get. So what I'm talking about is responsive regulation that's fair and balanced. And one of the key things is the attitude, behaviour and level of compliance of the provider. That's what we're regulating. The standards belong to the provider. The provider does the job. They lead the whole thing and provide this service. And their attitude and their behaviour and level of compliance is absolutely pivotal. Most providers are motivated to deliver safe, high-quality care, and then the authority recognises that a minority of providers are unwilling, incapable, or ineffective, and that is a fact. So we can't walk away from that. And we're regulating the disability sector now as well. And our job isn't necessarily where you have, and I'll come back to the principles we use, but where you have someone who is unwilling, incapable, and ineffective, we have to step in. And very often, I don't know if you find this in life, but the most uninformed people can sometimes generate an air of competence that when you just unravel it a bit, you can go behind and find different things. So you have to take your time, and you have to take your time about it. Responsive regulation is flexible in deciding what is the most appropriate and proportionate response. So it's not about running in there, closing people down. It's not about being hard hitting. And I'll come back to that about what that indicates. I've worked with people, providers, who were really, really struggling, where abuse took place in the centre, where they couldn't cope with the abuse, they couldn't do anything about it. They have actually turned their service around, and I can sit comfortably with that provider because I know they've learned a very, very harsh lesson. They've put in place systems around it, so there is learning. So it's not about just attacking people. We actually want to empower providers because there is so much expertise out there, it is unbelievable. If we think of the health system we regulate, it's public, private and voluntary. It is a competitive market though as well, which does make a difference because it doesn't necessarily generate the sharing of information that you would like. There's a competitive market out there in terms of people for nursing homes. Essentially, responsive regulation is about targeting resources. Where people are compliant with a good attitude, where they have the systems in place, we only want to see you once every 3 years where we're assessing your fitness. We want to target our resources where the most risk is. And we have a lot of indicators of that. We do a lot of profiling of centres. So we receive information vis-a-vis notifications. So people notify us of allegations of abuse. We receive information from the public via what we call our information handling centre. So we encourage any member of the public who believes that there's a breach of the regulations and standards to contact us directly. And then we also inspect. So we're able to triangulate and build up a picture of people over time. And we've been regulating since 2009. So we have a lot of intelligence in which to target our very, very valuable resources. So essentially what we do then is, the frequency and intensity of inspections is based on the amount of risk that we see. Okay. At the same time, we need to be able to justify our decisions. So it's only right that a provider is treated fairly and transparently, and we've an array of policies in place where they can make submissions about action plans, about reports, etc., etc. And we'll go through that and take it on board. And in fairness, I would say that where providers do make submissions, there's valuable learning in that for us, and for them. And so that is a useful exercise. Okay, the interventions we use. We monitor the centres through the receipt and assessment of information. We risk assess every piece of information that comes into the authority. It absolutely is onerous, rigorous and requires a lot of work. But for example, you might have 13,000 pieces of information. Each one is individually risk assessed then and applied onto another layer of information. And then the inspections change based on that. We use both announced and unannounced. Now, the narrative in the public can be about, generally people like to comfort themselves with the idea that if you arrive unannounced at a certain time in the morning, you'll really find out what's going on and you'll catch people out and you'll find the reality. That is not strictly true, because one of the things about an unannounced inspection is you don't get to speak to the people who are receiving the service or give them advance notice. So for registrations, we announce the inspection so we can listen to the relatives, so that the staff get time to speak to the residents, to put up posters and say that the inspectors are coming, and you get a lot of valuable information there. Now that said, the majority of our inspections outside of registration are unannounced. And really there's a number of reasons for that, and they can be valuable, but there is also a value in the announced inspection. We've also brought in recruited specialist staff, so in terms of medication and also fire and building. And that's because since 2009 we've been regulating, we've a lot of information. The sector is relatively compliant, and now we want to move it on again. So we want to get down into the details. So I think someone mentioned about the medication this morning and the idea of chemical, restraint. And of course, we as a regulator have to be very balanced in how we do things, and that it's based on the law and based on an infrastructure. So the idea of looking at medication with the sector to see if it's the right amount of medication. I don't know. I remember when I was training as a nurse, there was a drug called haloperidol. and you could only ever get it in 5 milligrams. And I always remember a professor came back from America, actually Ian Lawler was his name, and James's, and I remember him coming back and saying, oh my God, you're giving people 5 milligrams of haloperidol. That's outrageous. And he told us about a bouquet threshold where eventually they'll become confused and fall, etc. It wasn't that anyone was trying to chemically restrain anyone. It was just that's how the system worked. Now you can get that in 0.5, 1.5, so it's actually much more effective. So it's looking at the systems that way, but we've actually recruited people specific for medication management. We believe that that's a relatively big issue, and also the premises. So for example, if I was to talk to you about the premises, you know, at this moment in time, and we've been teeing this up for a number of years, I as head of older persons in Ireland, in regulation, am not satisfied with some of the physical conditions that some of our most vulnerable older people are living in. I'm not satisfied to register those physical conditions so that our vulnerable people are living in wards of 20 or 25 in some places, living out the rest of their life in those conditions. Not satisfied to do that, and so what we do is we put in place a process to mitigate that. That can generate anxiety in the larger community, in the political community, in the community itself. But you know what? Sometimes that's just what you have to do. You have to get into the car and drive the road and see where it brings you. And that's what we're doing at this moment in time. That in itself, the project's been going on for about 1.5 years. The response from the providers to that has been quite good, actually. I have to say, I have to give credit to people, both in the private and the public sector, in terms of trying to put the levers in place to replace the bed stock so that people have dignity and have privacy, and that their care and welfare is attended to. Just to say, the principle that we tend to use is an ARI principle, the attitude, the risk and the impact. So what's the attitude of a provider, what's the risk and what's the impact? I have no problem with someone having a bad attitude to the regulator, because people, as I say, have different views. Someone is working hard to have a really creative business, and the regulator might pick them up on something that they don't see as a major issue. I may perceive that as a bad attitude. I actually don't mind that, so long as there's very little risk to the residents. However, if there is a bad attitude and there's quite clear there's risk to the residents and it will impact on the residents, that's helpful in forming a view on how you might act. We then have statutory enforcement powers, and I was very interested in the paper there about the deregistration of nursing homes. Yeah, we've cancelled a number of registrations and we've refused to register a number of nursing homes. We've taken people out of the business. They may no longer carry on the business, and the reason for that is because they were unfit to carry on the business and they were placing people at risk. So they no longer do that. There's different ways of doing it. There's the poor people who have no insight, and so we just do it vis-a-vis the courts. There's other people who, on reflection, the business has become too complicated for them, where they are in their life, and they voluntarily accept the cancellation. The one thing that sticks in my mind about the nursing homes we closed down was the especially vulnerable one. And it wasn't too far from Lee's Cross. It was a nursing home called Creve Lee. Again, this is a published report that is on the authority website. But I always remember going in there, and we have a basic rule of seek out the most vulnerable. You'll always have people up the front who are looking well, and the hair's looking well, and doing all the different things. But going into a nursing home, seek out the most vulnerable. Where are they? And when we went into this nursing home, there was a lady down in a single room on her own. She had cancer and she was in pain. And she was really the factor that made us think, right, there's something desperately wrong here in terms of the most vulnerable. And then we teased it out in the lack of insight, and you could see there was a systems breakdown in that nursing home. There was nobody in that nursing home deliberately abusing someone or going into work intending to hurt another vulnerable person. There genuinely wasn't. But there was a systems breakdown, and this person was being neglected, the most vulnerable. So it just, some of those examples show you the need to use these powers. But what we do is we have the powers to prosecute or to apply to the courts to cancel. They are quite strong powers. Just to give you an idea of the compliance spectrum, there are so many good providers out there that need to be rewarded. Unfortunately, and they're rewarded in terms of the supply into their nursing homes. The nursing homes are always packed, or the units are always packed. There's always people there. We publish reports which show a high level of compliance with no actions. Never do they hit the media. They've never hit the media. The good nursing homes never hit the media at all. And those champions, it's trying to reward those champions and use those champions to lead the way forward. And where people are compliant, we recognise that compliance. Then there's the confused, and you're trying to enable the confused to reply. Now that is not so evident now in the sector, because you've had a highly regulated sector for 5 years with highly informed people. It's not easy to have a light shone on your sector. Now this is only a sector with 30,000 people. I'm not talking about all the other older people in Ireland, the other vulnerable people. So this is a fairly well-regulated sector. Then there's the careless that need to be informed. But then we come down to this thing, the badly intentioned and badly informed. That's what we're watching out for. And we just need to be, we're absolutely mindful of that. So just to say, I wanted to get a sense of action here. We have to live in the real world, in the here and now. It's not pretty. It reminds me of World War I, of being the people who are caring for people, the providers, the nurses, the care staff. They're kind of in the trenches, you know. We're very near to the trenches, and really what we need to do is make sure that back there in the chateau, about 2 kilometres away, people planning and how we're doing things. Really, that's what we need to think, and we need to get the narrative through and get the thinking through at a systems-based approach. Because there is no more pleasurable thing I find in life than going out and in working with providers where they have worked on the blunt end. They've done the relentless work on the blunt end around governance, culture, processes, training. And it's actually amazing to go into those places, and you can actually nearly touch the care that's going on. But the places that are struggling, what you'll find is a lack of governance and leadership. And I'm not saying that's about any individuals. I'm genuinely not saying that. If you don't have the resources, if you don't have the money, if you're struggling in a system with too many balls to juggle, these are the things that come out from staff and managers when they speak to us. There's a rush. Just stop. Can we stop here now? Can we look at what's going on? Some people don't have that luxury in the services. So what we find is if people take the time and can actively get the time in terms of the governance, leadership, culture, audit, that the sharp end incidents, the Oris Attracta was waiting to happen. Oris Attracta will happen in any centre where the governance, leadership, the culture, the processes, all that blunt end stuff isn't happening, is waiting to happen somewhere else. So we have to invest our time, our intelligence, our brains, our people in this, and hopefully avoid the sharp end, which we hope then will ensure the protection of the vulnerable. So that's us.